Nair sir, Dr. Shefali madam from AIMS, who's an expert in this area of neurology, and of course our moderator, Dr. Vineet Wankade, who's been the secretary of the IAP Neurology chapter, and all those panelists and speakers of today. We have Dr. Preeti Srivastava, Dr. Anusha, Dr. Ekta Agarwal, and Dr. Praveen Kumar, another pediatric neurologist, who will be sharing their expertise and discussing common problems of adults in neurology, especially focusing on epilepsy and a common problem headache among adolescents. So we at the Central HA are focusing on conducting super specialty webinars every month on the first Thursday, and we had a super successful, attendance. And basically, it was a very interesting topics were taken. We had never done this before. So the pediatricians who have been working with adults in health, they're already been working on many other topics which are dealing with adolescents. But regarding the super specialty topics, it is the first time we are touching upon like adolescent psychiatry, adolescent dentistry, adolescent cardiology, gastroenterology, likewise. So this month we have selected adolescent neurology. This is the silver jubilee of AHA. So we are in a very celebratory mood to actually to celebrate all the contribution of all our past chairpersons who have founded this chapter and we are want to carry the legacy forward. And I invite all of you to the National Adults Con also, which is going to be held in Ahmedabad. And we have done many innovative things in this year, like involving the youth in RR programs, vaccination drive. We had a male adolescent boy module. We also had a youth wellness module, and Wave 18. There is exclusively for the young people and engaging the young people, the youth of our country. So parenting module with the frequently asked questions, we had a consensus statement uploaded on the website. So these are some of the activities of AHA, and we really thank all of you to share our expertise today. And I request our chief guest and the guest of honor and the MKC Nair sir was very keen. It was he who has told me to take up the super specialty topics as a theme for this year. I really thank you, sir, for guiding me to take up the topics as webinars for the super specialty of this year. And it was really well appreciated throughout the country. We are in September, and we have done very successfully all the webinars. Over to you, sir, for your message and on this topic of adolescent neurology today.
Asking me?
Yes, sir.
Okay. So good evening to all. I think we have a good mixture of older and younger pediatric neurologists or those pediatricians interested in neurology. And we have I can see a beautiful faculty, very esteemed faculty. And my only request to all of you is that this is not a group of pediatric neurologists. So our knowledge in neurology is limited. Please don't go high fluent. Try to give us simple messages that we should not make mistake in our practice. Very often we think something is behavioral, something is related to leftover of autism, ADHD, and all that. But actually, it may be something more than that. So, what we need is that clue where you should not go wrong, where you should refer to a pediatric neurologist. And mind you, the biggest problem I find is particularly I'm feeling it now after Dr. Mohammadugunji was supporting me, but now because of some illness, he is not, he's not okay to come. So I'm finding the difference when I send to adult neurologists for opinion, things are not so okay because the interpretation of EEG is different. The interpretation of even MRI is different because as the baby becomes smaller and child becomes smaller and smaller, their interpretation is adult interpretation, and that I may not agree with it. I do have sometimes problems. So that is the area that you should be focusing on. What is the difference between a bigger child and a smaller child sometime? Thank you all very much. I'm looking forward to a very fruitful thing. And as for Shefali, again, I'm telling you, we are so grateful that you are part of this story, because I have not seen a more researcher in pediatric neurology, a fantastic clinician, very, very good teacher. The only problem is her IQ level is so high that smaller people like us can't follow her.
Oh,
We find it
doctor.
No,
difficult.
sir.
That is the only
That,
problem I have with
that
her.
don't pull my legs so
Modesty at its
badly.
highest level.
Yeah?
Sorry.
Modesty at a high level.
So don't go at 140 IQ level. Go at 100, 110, that we can manage.
So
Okay.
nice of you.
Thank you all.
Sir,
Thank
thank
you
you
all.
so
Thank
much,
you.
sir.
Thank you.
Thank you, sir.
Yeah.
Thank you, sir.
In fact,
Happy
sir, your
Onam.
presence
Enjoy
today,
Onam.
yes, sir, your
And
presence
happy
today, in
Onam for
spite
all.
of you're present today in spite of being Onam festivals going on in Kerala. So huge gratitude on behalf of Central HA for your presence and always guiding us. Thank you, sir. We request you to kindly stay on as much as possible. And now I request Dr. Shefali, madam, who has agreed at very short notice. Just 2 days back, I called her. I said, Shefali, we cannot have a neurology webinar without your presence. I requested her, and she so kindly, graciously accepted. I also told her to kindly be available throughout the webinar and give her expert comments during the event panel discussion. And I requested our moderator, Dr. Vineet, to take her comments at every, at the end of every question. So, Shefali ji, you are our chairperson for the day. Request your message in the beginning for this webinar.
Thank you so much.
And I want to introduce you, please, 1 minute. We all know her, Sir M.K. Sinha said, even I appreciate Madam Shefali for her intense interest in the neurology. And she made us all proud. Being a pediatrician, she has gone so far. And she's so evidence-based and so much work she's doing at AIMS. We all know that she's having over 31 years of experience she's now the program director, for the pediatric neurology program. And that's really great of her. She's a faculty in charge for the Center of Excellence in Advanced Research for Childhood Neurodevelopment Disorders, Child Neurology Division, Department of Pediatrics, AIMS, New Delhi, India. And she's adjunct faculty of the National Brain Research Center, President, Association of Child Neurology, India, and a founder member of, she was founder member in 2002. She founded this association. I think national delegate in the India and executive board member. She's also abroad in the Asian Oceania Child Neurology Association. She was the president of the 17th Asian Ocean Congress of Child Neurology, editor of many journals, and I think so much more she's there on the in her CV. I would like to highlight that she was executive board member of Indian Epilepsy Society also, and of course member advisory board coordinator to the neurodevelopment disorders module. She has many publications, 516 publications to her credit, and thank you. And she's been a recipient of many awards at the national, international level, and Women in Medicine Award and Best Teacher Award, recognized for many of her achievements. We are very, very proud of you, Shefali, a huge gratitude, and we want to work along with you. And please guide us on some research topics also. AHA would like to take it up. A few messages for us before we start the webinar, and we request you to kindly stay on for your expert comments.
Yeah,
Maybe a
Himabindu,
short message. Yes, sir.
Himabindu, one more sentence I want to say. I'm waiting for the day when our Prime Minister will recognize her like he has recognized Sundar picture. Something
Sure,
like
sir. We
that.
all pray and wish, and we
Yeah.
can, if possible, even
And
advocate.
her contribution, I realized her talent when we did the neurodevelopment disorder international study,
Yes,
where we came out with a neurodevelopmental screening tool and 4 England tools for
correct,
ASD, ADHD,
sir.
epilepsy, and neuromuscular. And
Sir,
critical academic content was provided by her. And
sir.
that's when I realized the capacity of this, at that time, young girl.
Yes, sir.
Now also young only, but little middle.
Yeah. Thank you, sir. We all
Also, my
appreciate.
prayers for you to be recognized by Prime Minister Modi,
Yes, sir. Yes.
Dr.
Over to you,
M.K.
Dr.
Sinha.
Shefali ji. You would like to share a short message now?
Yeah, actually, I'm overwhelmed and I don't have any words. I mean, I feel so overwhelmed, and MKC sir has been really a big mentor for me. And I think I'm really humbled by all your support. And I think one thing we all should understand, and which we don't talk about in any fora, that we all have to have a humanistic view of life, and every right has equal right for a dignified life. So whenever any child comes to us, we have to look and treat as if they are our own child or ourselves. So I think that is something important. And for neurology, the 99% of things you come to know from history, and your examination starts from right the time when you having the child walk in. And even in adolescence, they may not say some things, but you'll have to observe. Your observation powers have to be really, really strong. And that is how I feel you should look at child neurology and overall pediatrics as such. I'm really overwhelmed, and thank you for having me over.
Thank
I'm
you,
always there.
Shefali.
I'm always there. Just if 30 seconds, we're having the 17th Asian Oceanian Child Neurology Congress in Delhi, Yashbhumi, from 17th to 20th of this month. And on 16th, we have put 8 pre-conference workshops,
Wow.
on various talks. And 21st, we're having a post-conference workshop for pediatricians. So, I mean, you're all welcome to join. And
Thank you.
it's coming to India after 21 years. And I wanted to correct the AOC in India was founded by my mentor, Professor Veena Kalra. And that was there. I mean, DM Pediatric Neurology program, we started the first in South Asia 21 years back. So Professor Kalra and myself, we both jointly started it
Right.
21 years back. Thank you.
Thank you, Shefali ji, for that
Thanks, ma'am.
nice, crisp message for the pediatricians to be more humanistic. And history is a key. Yeah, I think that we have Dr. Srinivasan sir, one word from you, and because it already is 9:15, we would like to
Yeah,
start the
yeah.
sessions.
All stalwarts are here
Srinivasan
and
sir,
they have blessed you. So continue.
thank
Wish
you.
you all the best. And
Thank you,
thank
sir.
you very
Dr.
much.
Sushma Desai, madam, Dr. Geeta Patil, short message from you. Dr. Sushma ji, Dr. Geeta Patil. Okay, so I think we should start this session. We have the plan is to have a small lecture first on um, epilepsy, and then we have the panel discussion by Dr. Vineet. So I'll be introducing two of our faculties today. Dr. Praveen Kumar, he'll be deliberating on the epilepsy. So he's a
Headache, ma'am.
senior consultant, right? Senior
Yeah,
consultant, head of
ma'am.
the division of
Topic is headache.
headache. Okay, okay. So,
Yeah.
the senior consultant, he's the senior consultant, head of the division of pediatric neurology, Institute of Child Health, Sir Gangaram Hospital, New Delhi. And his areas of interest are epilepsy, stroke, CNS demyelination, and headache. Currently, the secretary of the Association of Pediatric Neurology at Delhi, Best Senior Resident Award at RML Hospital. He also got the Young Achievers Award, Most Trusted Pediatric Neurologist, authored a book on Manual of Pediatric EEG, co-authored Handbook on Pediatric EEG, more than 50 publications, and he's always secretary of Annual Pediatric Neurology Update, at which is conducted by the Gangaram Hospital, Delhi. Over to you, Praveen ji, for the lecture, and followed by that, we'll be having Dr. Vineet, who will be moderating the session on epilepsy, right? And common drugs, what to use, which is very commonly we see in our day-to-day practice. So Dr. Vineet is a National Secretary of Academy of Pediatric Neurology. He's from Nagpur. He's the Director of Kids Neuro Clinic Hospital and is a consultant pediatric neurologist and epileptologist, postgraduate of university topper, gold medalist, postdoctoral fellowship in pediatric neurology, All India topper from Trivandrum Medical College, academic editor, textbook of child neurology and beyond. So these are the two, stalwarts. I mean, who has done a lot of work in this field. Who's been office bearer also, Dr. Vineet in pediatric neurology. So with this small introduction, I first invite Dr. Praveen to start his presentation.
Okay. Thank you, ma'am. Can I share my screen? Yeah.
Yes.
Can you see my slides?
Yes, yes,
Am I audible now? Yeah.
Yes, yes.
yes.
Yeah, so thank you very much. Thank you, Dr. Sudhir Misra, sir. I mean the central AHA, my colleagues from central OPMs, Fali ma'am, Naya sir, and the words of wisdom which you started uh, about the history and keeping it simple for the uh, day-to-day clinical practice. So it is my topic for today is headache in adolescents, differentiating neurological and non-neurological causes. So I'll be limiting about the approach. I won't be discussing about the management plan because of the time limitations also and because of the topic also on the part. So let us start with this case. This child came to me a couple of years back. He was the son of one of our doctor's colleague. Only he was studying somewhere close to Delhi in a hostel. A young boy who had living in hostel, and he came to us with the complaints of severe headache for past 2 days. He was not sleeping for past couple of weeks because he had the class 11th 12th examination, and then he had to appear for the competitive examination also on the part. He had history of intermittent headache in the past also. On examination, the common neurological findings were normal. He didn't have any significant neurological findings on the part. But when we got the scan done, what we are finding is a very a kind of like hyperintense lesion in the left thalamus on the part. When we do the MR venography with the contrast images, at the same time we are finding that he has got a thrombus in the straight sinus on the part. So what I want to understand, tell you in the beginning only is that a headache in adolescents can have multiple etiologies. So like this child who had history of headache in the past, commonly possibly like a migraine kind of headache, he had episodic headache in the past, and now he had come with the headache which was there in the background of him not sleeping well, which is quite common with the kind of like adolescent age group when they're preparing for the examinations, when they have to compete for the examinations on the part. But what he was having, so that is something which is a non-neurological kind of scenarios on the part. But what he was having was a headache which was happening for past 2 days, and it was different from the initial headache which was there comes in like intermittent headache for past many years on the part. So now past 2 days he was having very severe headache, and it was not letting him sleep at night also because of these headaches on the part. And he had normal neurological examination on the part. So it means an adolescent with a headache can have both the things. It can have a non-neurological causes also, like not sleeping well because of the examination part, and at the same time he had something very sinister neurologically. So history is the key. Like in this case, the him not having sleeping at night because of the headache gives you an idea that this is a serious kind of headache, and it's not like a typical primary headache part, and he requires evaluation. So headache in sleep always requires evaluation with the appropriate imaging on the part. Moving forward, we need to, yeah. So moving forward, we need to know a little bit about the anatomy which gives rise to headache, especially on the part. So intracranially, the structures like dura mater, venous sinuses, cortical veins, and basal arteries are the structure which gives rise to the headache part. Contrary to popular belief, our brain parenchyma is pain insensitive on the part. While extracranially, all the thing which is in around those brain area or the scalp area, like skull vessels, muscles, the orbital contents, the mucous membrane of the nasal, panel, sinuses, the teeth, gums, external and middle ear, they all can also contribute to the headache part. So now the crux lies in differentiating what is a non-neurological cause of headache, like coming from the teeth, coming from the gums, or coming from the sinusitis, or from the kind of like a refractive error on the part, or whether it is coming from the sinuses, veins, or the arteries. If you look at the intracranial part, that tells you that the dura mater or sinuses are involved or the arteries are involved. It means that even if you're having a child where you have to evaluate him for any intracranial pathology or any serious neurological pathology, when you're going for image of that child, you must include the contrast images. There's no point getting only plain MRI brain or plain CT brain in cases of evaluation of the headache, because all these sinuses, the arteries, you can only well visualize once you inject contrast. Otherwise, what happens that you get the MRI brain done plain, and when the child comes to us again, then we have to send the child again for the contrast, and the children require the sedation for the next imaging on the part. That's the second take home message, that whenever you are imaging a child with any serious neurological cause must include contrast images with your MRI brain or CT brain, depending upon what the situation is in these cases. Headache are primarily of two types. Primary type, where you don't have any underlying etiologies. Headache is the most important problem on the part, and the most common headache in adolescent age group are the primary kind of headaches like migraine, tension type headache, chronic headache, cluster headaches, slightly less common as compared to the migraine on TTH on the part. While secondary causes, although they are less common, but they are the most common kind of like anxiety provoking causes. So like meningitis, venous thrombosis, brain tumor, or many a times even the fever on the part. So when you talk about the neurological and non-neurological causes, so like meningitis, thrombosis, like in our child, they all become a neurological cause, while fever and headache, which is like a toxic headache, becomes a non-neurological cause. So the whole crux lies in differentiating a child or an adolescent who comes to us with headache, where this is a kind of like neurological headache or this is a non-neurological headache, where this is a primary headache, which is the most common type, or this is a secondary headache, which has got the more sinister prognosis on the part. We'll see subsequently that how we can differentiate these ones based on the history and the relevant examination on the part. The International Classification of Headache Disorder 2018 have also differentiated these ones as a primary headache, as I mentioned to you, then secondary headaches, and the neuropathic and the facial pain with the headaches. So that means even if you have got some furuncles over the pain, they can also contribute to your headache, and that is a non-neurological cause of the headache in a way. Similarly, you can have also headache because of the psychiatric disorder, which is also very common in the pediatric age group. That becomes a secondary headache on the part, or headache because of the facial pain or some problem in the cranium, neck, eyes, ear, nose, sinuses, as we discussed, that also becomes a secondary headache, and that is mostly non-neurological headache on the part. While primary headaches are definitely neurological headaches on the part. So the whole the gamut is dividing into the or delineating this is the primary versus the secondary headache, neurological versus the non-neurological headache on the part. Many times the temporal pattern of headache, once known by a good history, helps you that this is primary versus secondary, or this is which kind of headache is that. If you're having an acute headache, that can be because of anything like fever, meningitis, hypertension, any bleed on the part. Acute recurrent headache, which is like an episodic headache, is mostly migraine in the nature. Chronic progressive headache is something very serious. You need to follow any significant intestinal pathology. While chronic non-progressive headache is a kind of headache which will be mostly because of maybe migraine kind of pathology, which has been superimposed with the chronic daily headache, or maybe some psychiatric illness on the part. So having a good history, how often the headache takes place, are you having a kind of like gap between the headaches part? Is it episodic or is it happening on a daily basis? That tells you that what kind of headache you are dealing with. It's like a primary or it's like a secondary. Is it like something very serious like chronic progressive, or it's like a migraine kind of, which is an episodic headache on the part. We've got different etiologies for these kinds of patterns. Acute headache can be because of the fever, sinusitis, meningitis, as we discussed. Hypertension can give rise to acute recurrent is migraine and those kind of pathologies, which is unexplored otherwise. Chronic progressive, again, you have to look for any brain tumor, brain abscesses, idiopathic endocrine hypertension. Chronic non-progressive is again a migraine variant, or maybe the psychiatric illness along with the headache on the part. And you can always have a mixed kind of headache. Mixed can be like in our first case, a child with episodic headache now coming with a kind of like very acute headache, and that is to be evaluated in those parts. Look at this child. This was a young child, 14 years of age. She comes with the acute severe headache and acute vision loss. He had history of headache in the past also, but when we get the blood pressure, we find this is on the very high grade, and the MRI is showing bilateral posterior hyperintensity. That is a case of posterior reversible encephalopathy syndrome on the part. So it means if you look at the previous slide, the blood pressure, the hypertension can be cause of all these things: acute, intermittent, chronic. So BP must be measured in each and every case of pediatric headache. That is one of the take-home message which we need to go back. This other child who had come to us with a headache for past 1 month, which was increased in the lying posture, less when she used to get up on the part. Examination wide, she had 6 nerve palsy, bilateral. So also complaining of progressive vision loss. When we examined her, we found that she had got significant bilateral papilledema. Vision loss had become very, very significant, that it was almost to the finger counting on the part in a way. So we had to put her on finally for the lumboperitoneal shunt. despite because you're not responding to your normal anti-edema measures on the part. So this was the case of idiopathic intracranial hypertension causing headaches. So you got two cases, headache and vision loss because of the press, because of the hypertension, headache and vision loss here because this is a long duration, fundus showing some changes. This becomes a case of your idiopathic intracranial hypertension because you do the LP and you find increased ICP on the part. So here lies the role of you having a good examination and good clinical history to really delineate what is the possibility also of a headache in these cases on the part. And benign intracranial hypertension is quite common in adolescents because of their age groups, because of obesity also playing in a role, because of hormones also playing in a role, and we can't miss it because many times it can lead to very severe vision loss. Like we had a couple of patients where we had to go for the LPation. We published this case also a couple of years back in a part. So although headache is common, the serious causes of headache are uncommon on the part. You'll find that the brain tumors are very, very uncommon on the part. But that is the crux in delineating, or that is the, the trick, or that is the challenge in delineating those serious causes from the non-serious causes of the headache on the part. Many times you'll find that if the child is having any intracranial space occupying lesion, so most often you'll find some focal neurological deficits. Almost around the history is about the 4 months time, 5 months time, and if you're not finding the child having any focal deficits, this is very, very unlikely to be because of any serious intracranial space occupying lesion on the part. So focal deficits not happening in a child with a headache of around 4 months, 5 months, it almost excludes the serious underlying causes like brain tumor and those ones in a part. Many times we also worry that this headache can be because of any things sinister sitting inside the brain, like intracranial aneurysm, which can bleed on the part. So although aneurysm in the brain is very, very uncommon, we don't have any typical headache pattern by which you can distinguish if this headache is because of serious neurological issues like aneurysm on the part. But sometimes when you find the headache is only happening at one particular part of the brain, it doesn't have the other features of migraine like phonophobia, photophobia, nausea, vomiting, episodic part. You must evaluate them because that can be one clue to him having something serious sitting beneath that particular point where this child is complaining of headache day in, day out on the part. That's the one part. So coming to the next part, the history and the examination is the key for looking at these kinds of headache pattern. So there are a number of questions which you can ask in the history, but in the BG clinical practice, what I find that if you have got these 4 questions with you, they can solve your problem most of the time. This is a serious cause or this is a non-serious cause. This is neurological versus non-neurological. The first and the foremost is since how long you are having your headache. If the headache is for 6 months, 7 months, you're not finding anything significant, that has to be something primary, that has to be something non-serious cause, non-neurological one. Is it intermittent, progressive, constant? Intermittent headaches, as you said, is a migraine. Progressive is something serious on the part. Family history of headache, very, strong family history of headache can be seen in cases of migraine on the part. And many times if you ask adolescents, they can tell you, do you know what is causing your headache? So they can tell you, my peers, my friends, loss of someone in the family members, that is giving me the headache. And now you know the answer why this child is having the headache on the part. So these are the 4 common questions by which you can get a kind of like answer for your headache on the part. Key examination, top to bottom. In busy practice, look at the head, macrocephaly, look at the eyes, sixth nerve palsy, fundus, look at the neck, any meningeal signs, get the blood pressure done, shake hands with him. Do you find any asymmetry in the grip? Ask him to walk. Can he walk steady or does he walk it unsteady on the part? Most of the cases of pediatric brain tumors happens in the posterior fossa and they present with the walking difficulty, unstable walk or kind of like able to do the tandem walk on the part. So top to bottom examination fast can give you that this is a serious versus non-serious, neurological versus non-neurological cause for the headache in a part. So when do you need to investigate headache? If it is very acute short duration, like in our first case, headache with the Valsalva maneuver, focal deficits, papilledema, or a headache in the immunocompromised child because they can have something very serious sitting inside the brain, they need to be investigated with the imaging. Young children, because they can't tell you very good history, you can't examine them, you should be slightly more biased towards evaluating them. Although we see children as young as 3, 4, 5 years also with the migraine, but should be slightly more biased toward evaluating them before you tell them this is a migraine kind of headache on the part. And if you find behavioral changes, many times you find children can't tell you what is really happening to him. But if you find some amount of behavioral changes, child becoming much more irritable, he's losing his sleep, he's not talking much. That can also be a feature of your intracranial space occupying lesion because of the increased ICP on the part. Look at this child who came to me from the child development clinic because they were doing the therapy because of his torticollis. When I look at him, I found that he has got a head tilt, and he complained that he has got headache at the back of the skull. When I did this MRI, I found that he has got a kind of like a space occupying lesion in the posterior fossa. That is the another part, that when you have a child complaining of headache at the occiput, you must image them, because this is not a common cause for non-neurological headache. So we had a child with the headache in sleep, we must image them. A child with headache at the occiput, we must image them in those cases. And imagination and the image consists of CT brain or MRI brain with the contrast, not without contrast on the part. Many times you do the LP when you get the meningitis or increased ICP like IH, a kind of like clinical suspicion on the part. But if be aware that many times you can have on the MRI the findings which are not correlating, like pineal cyst or like temporal arachnoid cyst. So these are not kind of like correlating with the headache, but they can only be an incidental finding. So must be, you should be something, you should always have something what you're looking for in the MRI before you look at the MRI in the part. EEG is not recommended. You don't get headaches because of the seizures, which is very, very uncommon to have the ictal headaches. The practical purpose, EEG is not recommended for the evaluation of the headache in those cases. Coming to last couple of slides, the most common causes of headache in adolescents is migraine kind of headache, and most of the families, they do not know that they are having migraine on the part. The migraine in the pediatric age group, adolescent age group, differs from the adults. And Dr. Nair sir also mentioned that we need to know how the headache in pediatric adolescent differs on the part. It is mostly bilateral as compared to the unilateral, which happens in the adult. The photophobia, phonophobia, nausea is very important feature of the part, which is associated on the part. And the most important thing, that the child won't be doing his normal activities. He has to stop his activity in cases of migraine kind of headache on the part. It may not last for many hours as it happens in the adults. It can be for 30 minutes to hours only on the part, and they always get the sleep benefit. That's the characteristic. And many times when you ask the family, they will say they also get the headache, although they relate to their blood pressure, to anxiety, or to the cervical problem. But this is a migraine kind of pattern. And if you ask me, this was a young child. I won't play the video, but this was a young child with the deaf and mute. And what the mom is saying to me is this: they came to me from Kolkata, that the child suddenly becomes irritable. I mean, he doesn't say because it's different, but he behaves like an irritable. He goes to a corner of the room. He switches off the light. He rests there. He has some nausea, and he sleeps. When he comes out after half an hour, he becomes well on the part. And this happens episodic. So episodic kind of like behavior where he looks for the solitude. He looks for the dark corner. He has nausea. He rests. He becomes well. Is a migraine kind of pattern. So even a deaf and mute child, by the pattern, by the behavior, you can make out that this is an a migraine kind of headache on the part in a way. So episodic headache is migraine unless put otherwise. And most important thing is about them stopping the ongoing activity. They can't do the activities, and that differentiate migraine from the chronic daily headache or from the tension type headache, which we'll be seeing in the next slides on the part. So triggers for migraine can be anything like sleep deprivation, food, not having the good food, missing meals, or having junk foods, having screen time, noise, light, heat, and these all are very prominent in the adolescents. So they've got the sleep deprivation, the foods are not so proper, they've got high increased screen time on the part, so they have got very high chances of having headaches in a part in those persons. And if you want to, tell me as a clinician, that what is the one important thing by which you can tell this is migraine? I personally feel this is hypersensitive. A child with the headache because of migraine, adolescent with the migraine is hypersensitive to light, to sound, to sleep deprivation, to not having meals, or to having some different meals on the part. So this is something which is inbuilt, and it is triggered by the surrounding or by the environment. So hypersensitivity is one clinical clue which tells you this is a migraine kind of headache on the part. And in pediatrics, we have got the migraine precursors like we see tribal sickness, cyclic vomiting, syncope, recurrent abdominal pain. So they all can be a kind of like early features of migraine kind of part. Infantile colic also has been proved to be a kind of like migraine precursor. Children with infantile colic are more prone to develop migraine later in their life on the part. Look at this child. So this child is complaining that he gets headache over the forehead, band-like quality on the part, and he can continue to his ongoing activity. He doesn't have photophobia, doesn't have phonophobia, but this lasts throughout the day on the part. So this is tension type headache, and this is supposed to be the most common cause of headache in the adolescent. So a band-like quality, at times it can be bifrontal, but continues throughout the day, not obstructing to do the normal activities, and you define them as a tension type headache in those cases. Then other entities like new daily persistent headache, where you get the headache which is very abrupt, and that continues for a couple of months, almost around 3 months, and you also don't find any etiology. This is also kind of like migraine kind of headache on the part. Trigeminal autonomic cephalagia, which is less common in pediatric age group, like cluster headaches, hemicranial contivata, these ones. So I don't discuss in detail about these ones, but they require a further evaluation because they're not so common in pediatric age group. Last two slides. Look at this child who came to us with a headache. Look at the way he's doing on the part. So he's complaining of headache, but he's quite restless on the part, not following any particular pattern. And this was on his examination day on the past. It's not a kind of like typical headache you get very restless. Some children with the migraine will become, they're looking for the quiet dark. They won't have these kinds of behavior on the part. And this is something because of the psychogenic disorders. And this is also quite common in adolescent to have kind of like panic, generalized anxiety, post-traumatic stress, manifesting with the headache. And so they require management of headache also, and management of underlying psychogenic disorders, which is contributing to the headache in those cases. So headache in adolescents, so they have got both neurological and non-neurological issues on the part. And something which is very unique to adolescents is about hormonal changes. The female girls having the menstrual period, very prone to have migraine with aura and without aura. Lifestyle we saw, sleeping late because of their hormonal changes, getting up late on the part, missing meals, having food outside, defined behavior, not following the rules of all these parts, peer pressure that also gives rise to stress, kind of like tension type headache on the part, anxiety about the career, about the part in a way, substance abuse, which is also not very uncommon to have. So adolescents of us are prone to have. People say that parents who have got adolescents, they get the headache, but adolescents itself, because of their age, also get the headache, and which is quite genuine headache in these cases on the part. So to conclude, the headache is common, but most cases of adolescent headaches are tension type headache, which is a kind of like your primary headache, a kind of like migraine kind of pattern on the part. The most important thing which we need to do in pediatric or the neurology practice, pediatric practice, that we must make sure that we are measuring the blood pressure and we are seeing the fundus of all each kid who comes to us with a headache, not to miss the serious things on the part. And I personally feel that most of the cases of serious headaches can be found out by the good clinical examination. The thing where we really miss, what practically I find in the practice, is cerebral sinus venous thrombosis, like the first case. So adolescent with having very severe headache and headache at night. So must make sure that he's not having any venous sinus thrombosis in the part. And the second thing is about the prolonged headache, and especially in the adolescent who's slightly on the obese side, and we're not meeting idiopathic intracranial hypertension. And both can be diagnosed IIH by the fundus examination and CSBT by the intensity of headache without having any other significant findings on the part. So history is the key, as we have been told by Dr. Shefali ma'am, also Dr. Nair sir also, that history is the most important thing, even the neurology on the part. And most of these cases can be diagnosed or suspected based on an atypical feature of neurological causes for the headache on the part. Two important thing what I would like to emphasize is this: the headache in sleep always pathological. You must image them. If child comes at 2 o'clock, 3 o'clock in the morning with the headache, be very, very careful to dismiss them as a kind of like non-neurological headache in the part. And that is the one thing. And second thing, that if a child continues to have headache, but he stops his ongoing activity, he needs to rest. This is classical feature of migraine, and that differentiates it from all other things. A child with migraine will not be doing his ongoing activity. He has to rest. He can't keep on reading. He can't keep on watching TV. He can't keep on watching mobile on the part. If it is having headache also and is watching TV also, mobile also, playing also, this can be anything, but this can't be migraine on the part, which is the most important cause for headache in the adolescent age group in the past. So thank you very much. Thanks a lot for your time, patient time.
Thank you, Dr. Praveen ji. I think such an excellent key messages you have given. Dr. Shefali, madam, please, your comments as a chairperson on this topic.
Thank you. Thank you for a wonderful case-based approach, Dr. Praveen, as usual. I had
Thanks, sir.
wonderful cases. I think one or two points to be added would be like in eyes, many times these children have some refractory errors and they don't want to wear the spectacles, and that may cause headache. And sometimes their powers are increasing, they don't get it done, they have cylinders, all that. And plus, orthoptic test is important. Orthoptic test, because these small muscles of the eye, they get very frequently ignored. We don't bother about it, and they need some conversion exercises only. So you need to look for the orthoptic evaluation for these children. Plus, another area is psychogenic. Many situations they may be having psychogenic headache. So in case you are not able to explain something by organic, you need to understand the various other uh, ask more history about their schooling and their social thing at home, trying to understand. And we need a psychologist to assess, and then besides doing a childhood behavior checklist into them, we do things like some perception tests, like you do a house tree person test, ask the child to draw house tree and person, which is valid for actually up to 99 years. But we people are very smart, and what, we will draw a proper tree, a proper house, and a proper man, but these children, they may draw what they feel like. We have seen many patients we found of sexual abuse, and also in also situations why only this house tree person. So any times you have to also think, if you can't think of something organic, could there be a psychogenic cause, because that will just not go away without you understanding the cause and looking at it. I think that is also one particular area. In many SLD children, we found many, as I mentioned to you, a few cases of child abuse, but then we have had SLD children, ADHD children, and otherwise having other behavioral issues at home, and sometimes anxiety issues and adjustment in family, issue with parents, or yeah. And you have to also see there's a typical time for a headache which comes. Many times the headache is going to be coming only before going to school, but that is coming in the morning only on working days and not coming on Sundays. All those things you have to be very clear, and those are ancillary things in the history which will give you the cues. So, but otherwise, wonderful presentation. These few nuances we can keep more in mind. Yeah. Thank you.
Thanks, ma'am.
And one,
Very true.
and one,
Thank you,
But
ma'am.
yeah, one
Shefali, I
small
will
thing.
add two more
Yeah.
things.
Yes,
One,
sir.
END examination, sometimes cases, very important.
Yes,
And
sir.
second, nowadays, lot of adolescents who spend 6 to 8 hours in the evening or night on the mobile, they do have this problem. So
Yes.
that also, these
The
two are
screen time has to
reason. Yeah.
absolutely.
True.
Screen time is something which has come up in a very big way, and lack of sleep, and that leads to any morning headache.
Yeah.
That is something important. Yeah.
Yeah.
Good, ma'am.
Thank you, Dr.
Thanks.
Praveen Kumar.
Thanks, ma'am.
Thank you so much for sharing your expertise. Thank you, Dr. Shefali, Madam, and Dr. M.K. Sinayar, sir, for your expert comments. I think now it's time for starting a panel discussion. Dr. Vineet Vankade, over to you. We have already introduced you. Kindly introduce your panel, and he'll be speaking on another very common scenario and complaint what we get is very commonly we see epilepsy and how do we deal with it. What are the, I hope they will cover about the newer aspects and the practical aspects in the panel discussion. Over to you, Dr. Vineet.
Thank you, ma'am. Can you see my screen?
Yes, yes.
So at the outset, I want to thank
I can't
AHA
see.
President Dr. Hema Bindu Madam, all the doyens of development, Dr. M.K.C. Nair sir, Dr. Shefali Madam from Neurology side, and so many others are there. So thanks for the invitation, first of all. And thanks, Praveen, for making my task relatively easy, because we will be covering the different topics in neurology, and headache is the thing which we have covered earlier, because I was not aware of this talk. Anyway, but we'll skip through the headache. But so there are a lot of psychiatric disorders which are increasing as the day advance, and I think the adolescent is a peak where it all starts. So what are the challenges in the diagnosis? So what
Can you
is,
introduce your panel, Dr. Vineet, first?
in the next slide I will
Right,
introduce.
right. Okay, okay.
So first is the challenges in the diagnosis. There is a symptom overlap. So a lot of psychiatric issues and the neurological issues are, patients are coming in, and we are a little dubious what we're dealing with, because there is a considerable overlap. There is a developmental context, significant pruning of the brain circuits is occurring, increased risk taking and altered emotional response. This change can mask and complicate the disease. There is a communication barrier. So usually the adolescents are reluctant to talk, reluctant to report, reluctant to discuss, not with the doctors, even with their parents. So that's the third problem. And there is a substance abuse, the depression, and those things, which is called as pseudo regression. So what are the common diagnoses we come across is epilepsy, headaches and migraine, pseudo seizures, syncope, and a lot of those conditions like ADHD, oppositional defiant disorder, obsessive compulsive disorders, and of course, the drug abuse is on the verge. So for this, we have national experts and we have a beautiful ladies as a panelist, Dr. Preeti Srivastav, madam. She is a pediatric neurologist from the city of Jamshedpur. Dr. Anusha Raj, she is a pediatric neurologist and developmental pediatrician from the city of Mysore. Dr. Ekta Agrawal, she is a pediatric young dynamic pediatric neurologist from the city of Jamshedpur, Jharkhand, and Dr. Shailaja Srijit, madam, who is again a senior developmental pediatrician. So I think we have
Shailaja
seen
couldn't
the
join, Dr. Vineet.
yeah,
Shailaja couldn't join, I think, because of Onam. You can carry on with the rest of the panelists.
no problem, madam. So let's discuss few cases of headache. I will ask my panelists to be little brief because it's been already covered. So this is a 15-year-old female, recurrent episodic headache since last 8 months. Headache is precipitated by sleep deprivation and the dehydration. Now look at the type it is described. It is usually bilateral, frontal, pulsatile, associated with photophonophobia, and relieves with vomiting. So Dr. Ekta is there. Ekta, you are there?
Sir, I'm supposed to take this.
Yeah, Preeti, you can take this. So,
Yeah.
so this is a very important case scenario and which is very common. So in such scenario, just be brief because Praveen has already covered this topic, well elaborated. What are the key points in history which is important?
So, okay. Good evening, everyone, respected seniors and my dear colleagues. Thank you for this opportunity. Whenever we have a child with a headache, it's very important to take a detailed history and a thorough clinical examination because it helps us in distinguishing whether it is a primary or a secondary headache. So, the key points in history would be onset. Is it acute onset? Is it chronic? Is it progressive, non-progressive, episodic? The duration is important, like in this history we see that this child has been having this acute episodic headache since 8 months, and then what are the important aggravating or relieving factors? Like we see that headache is triggered by dehydration and sleep deprivation. And the area involved, again in the history, we know that it is bilateral frontal. And the nature and intensity, it seems to be a throbbing pulsatile kind of headache. So these are the important points in history that helps us to identify what the headache could be. So in this, based on the history, we have a presumptive diagnosis of an episodic intermittent.
So you made these
headache.
points in the history. What are the usual steps you carry out? So we will directly go for a diagnosis, or you will wait for the disease to progress? And what are the steps for the diagnosis? In short, if patients come with headache to you.
Yeah, so whenever we have this children coming with headache, it is important to understand whether it is acute or chronic. And then also during our history taking and examination, we need to identify red flags. Because if it is a primary headache, the most common headache in children, acute episodic headache or migraine headache or tension type headache. And so in order to differentiate it from secondary headache, could we move to the next slide, sir?
Yeah,
so this shows that different types of headache, like the acute recurrent headache, like a migraine headache. The child is normal in between and has these episodes of headache. While in a chronic progressive headache, like a intracranial space occupying lesion, where the headache is persisting throughout and it's going on increasing. Or it can be a non-progressive, it can be a chronic non-progressive headache, like a chronic migraine, which has
so
a
you want
distinct
to know
criteria.
first is whether it's acute, whether it's coming acutely, but it's recurrent, whether it's a chronic on and off, but it is progressive, or whether it's a chronic non-progressive. So if if you do that, so this patient had a acute intermittent unilateral episodic headache. So what is the next step? Well, can you tell us the
So
common red flags
it's
we should be?
important to identify the red flags because that will warrant the next level of investigations if we have any red flag in the child. So something like a sudden worst headache described by the child, early morning headaches associated with vomiting, fever with weight loss or altered sensorium. Then for presence of focal neurologic deficit in neurologic examination is an important red flag. If there is a history of trauma, if there is an underlying debilitating disease, sudden change in headache symptoms, or if there is an aura lasting for less than 5 minutes or more than 60 minutes, which is beyond the normal aura of migraine that we see. So these are the red flags which warrants further investigation. Like
In
in the
addition, what the Praveen said, the sleep, if it is disturbing your sleep and then you suddenly wake up in the evening, in the night, so the nocturnal awakening, those are the usual red flags. So in this condition, does it suffice the migraine criteria?
Yeah, so the most common type of migraine is the migraine without aura, and the other is the migraine with aura, which is the classical migraine. So the migraine without aura, it has a clear-cut defined criteria, and it should be fulfilling that. That is at least having 5 attacks, lasting for 4 to 72 hours, and 2 of the 4 characteristics should be present, like location, unilateral, but mostly in kids you see bilateral, temporal, and frontal region, pulsating or throbbing in quality, moderate to severe intensity, and aggravated by routine activity and relieved by vomiting or a good sleep. The symptoms would be lasting for more than 6 months. So these are
suppose, Preeti, you have said that the symptoms should last for more than 6 months. So suppose if the child comes with the same symptoms, but the duration of the symptomatology is 2 months, or the attacks are not, or 3 to 4 attacks, not 5. So anything, if it doesn't suffice the criteria of migraine by definition, what are you going to do? Will you be hurry up, please?
Yes. So even if it's not fulfilling the criteria, still we should follow this flow chart. And if the child comes with complaint of headache, detailed physical examination and history taking would, yeah. So
So you'll wait for that period to happen. Till that time, you will start an initial management in the form of headache diary.
So yeah. So the initial management, of course, with whatever headache the child comes with, and if we think it's a primary kind of headache, we'll ask the child to start maintaining a headache diary, because that will give us a trend of what is the frequency, what is the intensity of the headache, because the pain score is mentioned, what could be the triggers, and what could be the relieving factors. And it's also important to maintain a good
Can you tell something about the headache diary?
Yeah. So the headache diary, the patient is asked to write the pain score, say 1 out of 10, what is the headache like? And it makes the patient more responsible for the disease. The characteristics of the pain, the associated symptoms, like is it associated with photophobia, phonophobia? Is there any nausea, vomiting along with that? And what are the possible triggers? Is it sleep deprivation, excessive screen exposure? So the headache diary gives a trend of what could be the causes for the headache.
And how you overall treat? Just be brief, because Praveen has already covered this.
So the management of headache would be under 2 categories: the management of acute treatment, and chronic treatment or prophylaxis. Acute treatment.
Can you tell us the drug for the acute treatment? What are the common drugs?
So for acute treatment, usually the drugs that are used to relieve the treatment, first line we use as paracetamol or naproxen or ibuprofen, and if required, if the second line could be like the triptans can be used, and the triptans like commonly available sumatriptan, which is in the inhaled form, and oral tablets are also available. So that is for the acute treatment. Also like lifestyle modification that we have talked about, that should be advised. And if it is if it is chronic, if it is like very disabling and occurring for more frequently, say more than 6 or more days in
not all patients require prophylaxis.
Yeah.
So if at all you decide that you want to start for a prophylaxis, what are the drugs you choose, and what are the parameters you look after while choosing a drug?
So there are different types of prophylactic drugs that can be.
You can tell us what's the drugs, what you use?
Yeah, the calcium channel blockers like flunarizine. antidepressant like amitriptyline, anti-serotonergic drug like cyproheptadine, or anticonvulsant like topiramate or valproate may be used. So most commonly we use generally flunarizine or amitriptyline. And
So you'll see the comorbidity which is associated. You will see the patient profile. If the patient is lean, you will be more comfortable using valproate. If the patient is obese, you will be more selective towards topiramate, where the side effect is weight loss. If your comorbidity with stress plus tension, headache plus migraine, then you will be more choosing the amitriptyline. So that way, thank you, Preeti. So take home from the first case of migraine is you must know the basic outline. Keep a close watch over the onset, duration, and the progress. Categorize into those four types, whether it's acute recurrent, or chronic progressive, non-progressive. You must know what are the red flags, and there is a diagnostic criteria for every single headache, and unless that is met, you should not label it as a migraine unless if you don't suffice the criteria. Let's go to a very different case. So a teenager, Ekta can take this case. Yeah.
Yes,
So
sir.
left side, yeah. So left-sided headache with a ptosis, lacrimation. Ekta, can you tell us if you see any headache which is chronic, recurrent, but it is associated with the ptosis? What all things you consider?
So if the ptosis is persistent or ptosis is only with headache is an important thing. If the ptosis persists without the headache, then we have to think of it as a focal neurological deficit in addition to headache. But if the ptosis is only with the headache, duration of the headache, then we should consider it as a symptom and sign associated with headache. So that does not suffice to be called
Perfect.
as
So but these episodes are lasting 5 to 10 minutes and several episodes every day, but they're moderate intensity, recurrent since last 3 to 4 months. What is your take on? Will you go for imaging or not?
based upon the history. Actually, if we take the history, is very clear cut. It is acute onset, intermittent episodes, which are of short duration and occurring very frequently. The diagnosis based upon history is very clear cut. But neuroimaging is usually done to rule out any secondary cause or any other sinister cause which might be coexistent or which might be responsible for this ptosis or headache.
Because we'll take this ptosis as a neurodeficit. So any person
Yes,
with a headache with neurodeficits, you must go for a imaging.
headache.
So the steps for this diagnosis, can you just tell us what are the points which is important for the diagnosis?
So the onset is acute onset, progression, it's non-progressive, intermittent, episodic. Duration is around 15 minutes. No aggravating or relieving factor has been mentioned in history, but one of the red flag which is present is ptosis, and therefore neuroimaging should be done.
So we went ahead with neuroimaging. Can you tell us what is there?
So
Is
normal
there
MRI. It's
normal
normal MRI.
MRI? So what is this?
So this is a case of paroxysmal hemicrania,
Can
which
you
is a
tell us
type.
what is this entity is all about?
So it is a type of primary headache which comes under the group of trigeminal autonomic cephalgia. This is characterized by very frequent headaches. At least 5 can go up till 40 times headache in a day. Duration is usually about half an hour, but can extend from 2 minutes to 2 hours. And very characteristic, it is always on the same side. The headache is always on the same side. It is associated with some autonomic symptoms because of, as the name suggests, which will include the involvement either in the orbit or in the face. So the
But
orbital
Ekta, I am
symptom.
your examiner and I am telling you this is ophthalmoplegic migraine. Why it is not?
So the duration
Correct.
is very less. The
So
number of
duration in the migraine has to be more than 30 minutes.
30
And here
minutes,
it has to be, it is always less than
less
30
than 30
minutes.
minutes.
Another
And the
thing,
frequency, the number of attacks per day is not so much in migraine, like
and
55
strictly
to 40.
unilateral. Usually
And
migraine
always
headaches.
in, yes,
Correct.
always
Very nice.
unilateral.
So what are the autonomic features do you see
So
usually?
mostly it is in the division of either the eye or the face. So the eye symptoms can be in the form of redness of the eye, lacrimation. There can be nasal congestion. There can be ptosis, meiosis also. Along with that, there can be facial flushing. Very characteristically, it is also associated with some restlessness or agitation, which is one of the diagnostic criteria for
Perfect.
paroxysmal hemicrania.
So, as I already mentioned, these are the important types. The cluster and the paroxysmal hemicardium usually common in adolescent age group. Cluster is more common in the older males, and that is into 40s and 60s like that. So, why it is important and how does your management change? Because it has a totally different medicine. What is that?
So it has dramatic response to indomethacin. In fact, response to indomethacin is considered as a criteria for diagnosis of paroxysmal hemicrania. And
Correct.
most patients, if the frequency is lot, will require a chronic prophylaxis with indomethacin for at least 3 months. So depending upon the
So,
symptoms, the
indomethacin is not an abortifacient, but it also for use for the prophylaxis as
prophylaxis.
well.
Yes.
Thank you so much, Ekta. So let's go to another case. This is a 16-year-old male present with a history of continuous right-sided headache, conjunctival ingestion, nausea, no history of fever. Initially, there was a history of fever, but now we don't have a history of fever. Now there is no fever. In distress on examination, secondary to pain, right eye is injected, tearing, photophobia. Will you go for an MRI? Who's taking this case? Ekta?
Sir, hello.
Yeah. Yeah.
Um,
Anusha,
Hi, sir.
please.
Yeah, I'm Dr. Anisha. Yeah. So I'll be taking this
Yeah.
case. So here, as we discussed the history, initially there was fever and some congestion is there, and eventually the child has developed headache, eye pain, and conjunctival tearing. So these are some red flags. Initially, we could think some infection, nasal infection, sinus infection could have been there, but post after that there is developing of headache, which is significant, and there is eye pain. So in this case, we would be doing an imaging to see if there is any complication of the primary sinusitis which has spread and caused further complications. So
So
in
usually, so usually in the sinuses we have a sinus tenderness. But can any
right.
sinusitis lead to there is no sinus tenderness, but it still can be a sinusitis.
Yes. So if there is so sinus tenderness, if you're checking in your like frontal sinus and your maxillary sinus and ethmoid, you can check the sinus tenderness. But if there is deep seated, for example, your sphenoidal involvement, in that case, specific sinus tenderness may not be there, but there can develop eye pain and diffuse facial pain, and intractable headache can be there, and along with nausea, vomiting, and
So we
conjunctival
went ahead
redness.
with MRI. Can you just tell us what are the finding?
So in this MRI, we can clearly see the right side, there is opacification of the sphenoid sinus as compared to your left side, which is clear. And on the right side, there is a homogeneous opacification.
Okay, so lot of patients do have a lot of confusion, and the even doctors misdiagnose. Even they go to ENT side if the pain
Yes.
is over this side, which usually referred pathway. So often land up with the dentist. Dentist says it's because of the wisdom tooth which is sitting there. So
Yes.
what? So there are a lot many patients who migraine patients are seen by dentist. These patients seen by different. So what is real sinus and the migraine? So it's a beautiful study where 2,000, almost 3,000 patients or 450 sites were evaluated, and 80% had a migraine and they were misdiagnosed as a sinus headache. So I
Right.
think that is something alarming which we must know, that we must look at the symptomatology. We must see the duration of the headache. We must see the triggers, aggravating factor. Thank you, Anusha.
Right.
So,
Thank you.
so you want to add anything? Yeah.
So in the case of as we diagnose, if you're diagnosing a sinus headache, and especially in the adolescent, sphenoid is fully formed and you can have a sphenoidal sinusitis leading to a headache, in which has to be treated. Either IV antibiotics are given, and if it is severe, in those cases, you can do a sphenoidotomy is done. Either transnasal or balloon sphenoidotomy will be done in
So if you
these
have history of
cases.
swimming and this thing, usually your sinuses and these headaches are
Right.
very common.
Right.
So,
Right.
but having said that, another thing is rising trend of the burden of the migraine and the tension. You can see a clear peak of the migraine and clear peak of the tension. This is a very big study, which is done. Like they have seen the transition of the and the causality of the headaches in adolescent from 90s to 2020, and what they have found out, there is a surge of migraine and surge of tension headaches. So tension is if parents often come with adolescent, they ask me, sir, इसको क्या टेंशन है, तो ये आराम से रहता है. तो I always say टेंशन लेने का नहीं रहता है, टेंशन देने का नहीं रहता है, टेंशन लेने का रहता है. So often they land up in tensions. So always look at the symptomatology, always look at the distribution of the headache, always look at the duration of the headache, always look at the how frequently it is coming and what are the triggers. I think even if you do this thing, most of the headaches are diagnosed very easily. So headache is already covered. So we'll be moving towards an epilepsy, what we are supposed to talk. So let's come to a scenario. This is a 14-year-old girl with the first episode of unprovoked seizure. So now she had a early morning seizures, more than 5 minutes, and earlier she had a marriage reception party. So what are the usual steps when the any child with adolescent first time, because parents are always worried because it has been never seen, never witnessed, everything is developmentally okay, and now we have a seizures in a 14-year girl child. So who want to take this case?
I
Any
can
one
take
of
it.
you?
I can take it.
Preeti, please, what are the
Yeah.
steps for the diagnosis? How you approach such cases?
Yeah, so whenever we have a child with an abnormal event in question, the first thing is to confirm whether the event is seizure or not. So, and it is important to differentiate it from seizure mimics or
So what are the common
non-epileptic
seizure
events.
mimics you see in adolescent?
Yeah, so it can be like a psychosomatic, it can be like a
It can be a syncopal attack, it can be
Syncope.
yes,
parasomnias.
it can. Yeah. So it can a non-epileptic event, paroxysmal non-epileptic event should be ruled out. And but from this history, we see that the child, this girl had early morning seizure. Looks like she had the event in sleep. So looks most likely to be a seizure rather than a non-epileptic event. And also mentioned is that she was attending a marriage function. So looks like there was some degree of sleep deprivation, some function she was attending. So this looks like a seizure, and and it's important. Once we have identified the if it is seizure, then the next step would be to identify whether it is a focal onset or generalized onset.
I
So
think that is very important. So a lot of cases, lot of the residents who see the cases in the medical colleges and this thing, they often say every single seizure is GTC. So how
yes.
many GTCs are real GTCs, or how many? So Preeti,
So, like a significant number of seizures are actually focal onset seizures, but
correct?
it is mislabeled as generalized tonic-clonic seizure. And so, it is a detailed history is very important to see what was the pre-ictal, what was the ictal, and then the post-ictal. Like we take a proper history of seizure. So, in this one, the details are not there, but early morning seizure would most probably be a generalized tonic-clonic seizure, could be. And sleep deprivation, again, we know that sleep deprivation can be a trigger for generalized seizures. So it's also important to rule, like it is mentioned, it is important to look for provoking factor. In this one, we see a sleep deprivation to be the one. And then
Correct. So
next.
almost two-thirds of the patient have a focal onset and one-third may have a primarily generalized. So if you have focal onset, ultimately it'll end up into a secondary generalization, and what we observe at clinic is this generalized seizures. So our approach, if you have focal onset, is totally different. If you have a generalized GTC, because GTC should have those all three phases of tonic, clonic, and late third phase. So what are the risk factors what you identify? Let's go to a steps-wise thing. What is the
Yeah, so
checklist? The patient is in front of you. What do you want to check?
So obviously in the history, it is important to know, was there any significant perinatal event? What has been the developmental history like? And what is there any focal deficit present in neurological examination? Also important, which we overlook most of the times, is the school performance. Maybe the child has a normal developmental history, no neonatal event, no neurological deficit, but has been performing poorly, or his performance is going down in class. That is also a red flag to be concerned about. Also, any triggers like exposure to screen, then sleep deprivation, child having a tendency to drink less water, having a lot of junk food. So all these are points that we have to take care of in the history. So if
And the last set, yeah, please. And the last thing, what you said
yeah,
is the event detailed description of the pre-ictal,
yeah.
ictal, and post-ictal was already mentioned. So what is make you decide whether you want to start an anti-seizure medication?
So whenever we have a case of first unprovoked seizure, the question is, what is the risk of it occurring again? So it is around 30 to 40% in an unprovoked seizure. But the presence of certain factors increases the risk of recurrence. And those are if there is a significant perinatal history, if there is a developmental delay, if there is an abnormal neurological examination, and of course, if we have like the two important modalities of workup in any seizure would be a neuroimaging and an EEG. So abnormal EEG or an abnormal MRI, these factors would go in favor of starting treatment. But if we have a normal child having a normal development, normal school performance, normal neurologic examination, coming with first episode of unprovoked seizure, then the question is one has to weigh the risk of side effects of anti-epileptic to the benefit of giving anti-epileptic in the first go. So that depends from patient to patient, and along with counseling to the parents and taking their informed consent, one should decide whether to go for anti-epileptic in a normal child with first unprovoked seizure.
Correct. And I think this is very crucial in adolescent where the adherence to them doesn't depend on only parents, but also the child psychology. Lot many things come into picture.
Of course, the
So you
stigma that
have
goes with
to
labeling as epilepsy is an important factor. So it's
perfect.
one has to be very mindful in starting AED in an adolescent.
Thank you, Preeti. So this is again a 14-year-old girl. This is again early morning seizures, no family history, no perinatal event, no neurodeficits. So Ekta, can you take this? So we asked a
Sir,
question.
I'll continue with this,
Yeah,
and
you can
then,
continue.
sir,
Yeah,
I can continue with this, and
sure.
then later Dr. Ekta and Dr. Anusha can
Correct.
take.
So, is she? So I asked a question to her. Is she attentive in the class and outside? And the parents said for some months the teacher were complaining that she was a daydreamer. We're teaching and she's looking at some momentarily she's looking at different place. And when we ask a question, has she become clumsy in the morning, dropping or breaking glassware? And the answer was yes. She often drops in objects in hand, but we felt that it is just she's doing of her own. That was the parent narrative. So, can you interpret these findings in your epilepsology terms?
This is an adolescent girl. So could you just go back to the previous slide, please? Yeah. So this 14-year-old girl with history of first episode of unprovoked seizure. Again, she has early morning fits after a marriage reception party. No significant family history or perinatal or developmental history. Normal neurologic examination. So next slide. So and previously the parents give the history that she has been daydreaming in the class. I mean, the teacher was saying that. So it looks like probably she had some kind of absences earlier. I mean, this daydreaming and her becoming clumsy in the morning, dropping and breaking glassware, characteristically sounds like some kind of myoclonic events that are happening, like her dropping objects. So this is a case of a girl with first episode of generalized tonic-clonic seizure. Preceding that was a history of absences and some history of being clumsy, like having myoclonic jerks. So the next slide, please.
So what is this?
So first episode of unprovoked seizure, yes, we would like to go for EEG. And will you go for an MRI brain? So we would like to go for an EEG, but MRI brain in a normal child with normal development, normal perinatal history, normal neurologic examination, I would like to wait before going for an MRI brain.
You can say you can first go for an EEG. Let's look at the findings and then I can decide whether to want to give. So we went ahead with the EEG. So EEG, there was nothing, but on hyperventilation, we saw this type of response. And on photic stimulation, we saw this type of and what are the things you will order while ordering an EEG?
Yeah, so while ordering an EEG, a good EEG would be having an awake and a sleep recording. With sleep deprivation would be good because that is a kind of trigger that unmasks epileptiform discharges, and also the activating procedures like HVT and photic stimulation should be given. So that
just elaborate what is this HVT? People may not be aware of it.
Okay, so hyperventilation, where the child blows, takes deep breath for 2 to 3 minutes, and sometimes hyperventilation, as it is an activation procedure, it unmasks epileptiform discharges, especially absence. So a good American Clinical Neurophysiology Society, they lays down guidelines for pediatric EEG recording, and it says that these are the steps that should be taken in a normal routine EEG.
Okay, so hyperventilation and this photic stimulation is something which is mandatory in adolescents, specifically if they are first type of such generalized epilepsy, because you might get those abnormalities only after this activation procedure and not on the resting record. So this very important instruction you must give. So, uh, so we diagnosed as an epilepsy, and then the pediatrician, if this patient went to a pediatrician first, who started on carbamazepine. Though, so after starting of carbamazepine, there was no recurrence of seizures, but on follow-up, she had a worsening of scholastic performance, behavioral issues, but the jerks what were there earlier in the morning, so those jerks increased, but without a fall. What went wrong, Priti?
Yeah.
What was the
So
wrong thing?
this case was diagnosed as epilepsy and was started on carbamazepine, which is fair enough, because usually one of the three drugs one goes for, either valproate or levetiracetam or carbamazepine in normal practice. So
Dr. Neelam, can you please mute your mic? Yeah. Please, Priti.
yeah. So what happens is, after starting carbamazepine, there is no obvious tonic-clonic kind of seizure. So that part is okay. But there is a worsening of scholastic performance, behavior, and there is increase in the intensity of jerks. So it looks like probably carbamazepine has increased or intensified the myoclonic jerks part.
But do you feel that carbamazepine was the right choice?
No, I would say that carbamazepine was not the right choice, because if we have a
Why?
normal child with unprovoked seizure, normal examination showing generalized spike and wave discharges on EEG, the drug of choice for a generalized idiopathic epilepsy would be valproate. But for a girl, there has to be a special consideration, which we'll come on later. And so it would have been either valproate or levetiracetam, secondly, if there was a girl.
So pediatric neurologist has told this pediatrician that this is a generalized JME and you don't need a imaging. But the child is worsening and this thing. Will you go for EEG or will you go for an MRI?
So whenever a child on antiepileptic worsens, the question is the AED choice correct? Is the
Correct.
dose correct?
Perfect.
And then, after having come to a conclusion regarding those questions, then only a neuroimaging should be considered. Especially a child with normal development and a normal neurologic examination would be very unlikely to give anything more very revealing in MRI. So as you review the AED, carbamazepine doesn't seem to be a suitable antiepileptic, because it has
So we
worsened.
went ahead with the EEG. Can you just tell us what are the findings on EEG?
So in this EEG, we can see that there are generalized spike and wave discharges. Generalized because it can be seen in all the channels.
You can compare with the initial report, yeah.
And initially, we can see there's a burst of generalized spike wave discharges followed by normal tracings. But here in the next one, you see that the discharges in the next one, we see that the discharges are looking very florid, more intense in the amplitude and frequency. So it clearly shows that there is a deterioration in the epileptiform discharges from the previous EEG.
So what went wrong is because of the carbamazepine.
Yeah, so carbamazepine is counterproductive in case of juvenile myoclonic epilepsy, because its mechanism of action on voltage-gated sodium channel is actually goes on to increase neuronal firing more, leading.
So what are the drugs you want to use with the caution?
So, like, drug of choice for generalized epilepsy would be valproate. So in men, one can go ahead and use valproate, but in women, because of the side effect of it on the pituitary ovarian axis, risk of having PCOD, of course, secondly, overweight and all. So levetiracetam is more preferred in girls, and it should be tried as the first line in JME. And of course, if that fails, the other options are lamotrigine. And the second add-on or alternatives are topiramate and zonisamide. But the
What
drugs
are the drugs to be avoided?
yeah, the drugs to be avoided are carbamazepine, oxcarbazepine, and phenytoin because all three worsen the myoclonus part. They might control the general GTCS, but the myoclonic part gets worsened and it has a deleterious effect on that.
So we have started the patient on the steroids and we shifted the drug from a focal to generalized drug and the patient became absolutely all right. Let's go to another case. Ekta, can we want to take this case? So again,
Yes, sir.
again a same similar child, 14-year-old girl, no jocks, only vacant stares and have a generalized seizures. What is your take on Ekta? What is this?
So this adds vacant stares, often called as daydreaming, most likely the case of absence epilepsy because the age of onset is an adolescent. So we consider it as a
But
juvenile
Ekta, we
absence
have been
epilepsy.
telling since listening to so many people that absence epilepsy, the age group is 4 to 10 years. This is 11 years starting. Is it digestible?
So that is childhood onset absence epilepsy, which is called CAE. The onset can be as early as 4 years and goes up till 10 to 12 years. This is juvenile. The juvenile absence epilepsy has onset in adolescent, usually around 11, 12 years, but it can be as early as 8 years. And mostly it is seen around puberty, 11, 12, 13, around that years.
So
And
if
this
you had a
has,
doubt with, yeah,
yes,
please. If you had a doubt that whether it's a real absence or not, what exactly you want to do in a OPD?
so we can do a hyperventilation test to rule out whether it is absence seizure or it is actually a daydreaming. Hyperventilation will provoke a classical absence seizure in front of us and will prove the diagnosis to be absence epilepsy, like in this case.
Correct. So this is just a bedside test. If you are any patient who's having daydreaming and this thing, just ask them to do this maneuver for 2 minutes. And if you can provoke these episodes of staring spells, this is absence epilepsy unless proved otherwise. And then you should EEG or MRI, Ekta,
EEG,
if your
uh,
diagnosis is absence.
the first test and the preferred test is obviously the EEG. Again, during EEG also we should do a hyperventilation test because the rest of the EEG otherwise might be normal. Hyperventilation will show 2.5 to 3 hertz spike and wave discharges. In GME, the spike and wave discharges can be up to 4 to 6 hertz also, which have an abrupt onset and abrupt offset. So this is the EEG feature
So
of
this was a
GME.
awake EEG, which has shown again the 2.5 to 3 hertz spike and wave. And the wonder thing was in the sleep, there was a polyspike discharge, which usually is not seen in the case of childhood absence epilepsy. So, my question is, it is just if the age of onset is more than 10, you call it juvenile absence, or it is something different entity which is altogether different prognosis.
So we have two different names because they have two different entities in altogether. Childhood absence, besides the age of onset, the frequency of seizures are much more. There are daily multiple episodes, whereas in juvenile absence epilepsy, the seizure frequencies are not usually daily. Childhood absence epilepsy is a well-controlled seizure. Usually only absences are there. In juvenile absence, we often have other seizure types like the generalized tonic-clonic seizures. Some may also have some myoclonic jerks. And juvenile absence epilepsy is actually a lifelong disorder. The child requires medication throughout life. Most of them may not go off medication. In contrast, the prognosis of childhood absence is much better. Most of these children can be weaned off their drugs by adolescents or by teens. So the prognosis is much
So they
different
are
in
not
both.
as benign as
Uh,
correct. So they are not benign as childhood absence epilepsy and often require a polytherapy. So the thing is, in our scenario, I will tell you all these possible scenarios which can happen with the patient. So the patient was admitted in the government hospital, and the only drug available was that at that hospital was Gardenal. तो वो pediatrician ने सोचा कि कुछ नहीं है तो Gardenal start कर देते हैं because hardly I don't have any choice. The patient didn't improve, but there was no GTC, but that continued to be in the drowsy state. I think earlier it was just a staring spells, but went into a drowsy state. What went wrong, Ekta?
so I think we have been told first rule in medicine is do no wrong. If we cannot do good, let's not do wrong. So the
Correct.
wrong choice of AAD, just because there was no AD, giving some AD does not solve the purpose. So the choice of AAD in this case is wrong, because the mechanism for absences is very different. This child went into absence status
We
where
went
the
in
child,
EEG. Yeah.
yeah,
So EEG is showing a continuous 3 Hz spike and wave discharge. This is something which is called as absent.
absence status.
Correct. So what are the drug of choice we should be giving, and what are the drugs you must know that we should avoid and do not harm the patient?
So the drug of choice for absence is ethosuximide.
Is it
It is
available
now
in
available.
India?
Yeah, it is now available from 2019 onwards, 18 or 19 onwards in India. Earlier, it was not available. If the second choice is second or almost, when ethosuximide was not available, the first choice was valproate. In addition, if the seizures are persistent and the child has not responded, sometimes we can add on lamotrigine or clobazam. So these are the drug of choice for juvenile absence or absence. Carbamazepine is a strict no, just like for JME. Also, phenytoin, phenobarbital, gabapentin are the drugs. Vigabatrin also precipitates absence. So these drugs are strict no for absence epilepsy.
Take the another scenario. This is 14-year-old girl with the same episode of seizures, no family history, everything was normal before. But on the contrary, child is having a multiple episodes and having a drop attacks, ataxia, walking difficulty, deteriorating skill for scholastic performance. So the new neurodeficits are coming in the form of ataxia. What is your take on it?
So I
Sir,
think Dr.
I'll
Anusha is
I'll take this
Yeah,
case.
yeah, please,
So
Anusha, please.
commonly in adolescence, as we see, if there are myoclonic jerks developing, and common thing what we think of is juvenile myoclonic epilepsy. But most of the times we have to keep these cases and watch. If there is mixture of other semiologies of seizures, as you said, drop attacks, GTCS, and along with that, there is progressive neurological deterioration, like there is a cognitive decline, scholastic decline, and there is motor slowing, ataxia, incoordination, speech worsening, dysarthria is developing in these cases, and over the time there is a worsening course. In these cases, like if you have the acumen to pick these signs up and you're not just labeled as JME and you've just kept quiet, so you need to keep a watch how they're responding, whether they're responding to the routine treatment or it's a refractory case. So in these cases, we have to think of another entity which is called PMEs, which is progressive myoclonic epilepsies. There are more than a dozen types which are still developing. And so once we think of a PME, then all of them have a genetic basis. So we need to see which type of PME they fit into. And some of the common types which we have will just brush through. It's not possible in the scope of
I
this
can understand. I
lecture.
think only take home message for this thing. If
Yeah.
you have such entities with neurodeficits and this progressive myoclonus, you must
Yes.
refer to a pediatric neurologist as a
Neural.
replace.
Yes,
Yeah.
yes, yes, definitely. Yeah.
So let's go to another case. This is a
Yeah.
14-year-old male. NICU stay for hypoglycemic brain injury, but he was relatively doing okay, having a mild spasticity in the lower limbs with a mild speed, but otherwise doing perfectly in the schools.
Right,
MRI just
right,
suggests you a PVL. So what is this?
right.
Anyone take just 2 minutes
I
to,
will,
yeah.
I'll just take this case. So again, a 14-year-old, see, even though an adolescent comes in a pediatric OPD, the birth history is important, the development history is important. So because even though it's a new onset seizure at the age of 14 years, we still have to correlate with the birth history and how was the overall development of the child. So some
Perfect.
pointers in the history, birth, there was a hypoglycemia, and then child has spastic diplegia, and imaging also is showing some PVL-like picture. So in this case, we will think of remote symptomatic epilepsy. So because of the hypoglycemic insult in the newborn period, in the MRI, we can clearly see there is parietal occipital involvement, and there is an old hypoglycemic brain injury. And in the EEG, we can see there is right occipital spike discharges. We can classically see in the EEG in the right occipital region. And so these are the focal seizures which has occurred much, much later in the adolescence period. So the reason
Parents are
again,
often worried that the
yes,
birth has insult has occurred and the child was
yes,
okay for 14 years and now how come the
yes,
seizures has come suddenly?
yes,
So
yes,
it's very difficult to explain them at this point of time.
yes. Yes, yes.
Correct. So special consideration in adolescent, this is something. So you rule out the seizure mimics is the very important thing because lot many patients. Ekta, you want to take this? So this was a child. What is this? So such lot of episodes coming. Girls, adolescent girl with some stressor in the schools, abnormal tightening, not a proper description of that. This thing, pelvic thrusting movements. What is
So
this?
these are non-epileptic paroxysmal events, which were called pseudo seizures earlier. And you can see the effort he is taking to bring in that episode actually.
So
So
tell us
these
the clear distinction why this is not seizure because lot of seizures are maybe as subtle as just looking here and there.
So the description of the seizure or the seizure type may vary with the episode. True seizures will have stereotypic event in each of the episode, which can occur both in sleep and in awake. But pseudo seizures are always in awake. Most of the time, the eyes are open. In the case, can be open, or there can be version in the case of true seizure. But children with
Perfect.
pseudo seizure tend to close their eyes. And if
This
you
is
give
very
them
important finding. You must ask the parents or the witnessee whether the eyes were open or closed. I think this single point can give us a very important clue. We
often, if
require
we
only
can
two,
give
3 minutes.
if we can give them some question, some provocation, they can reproduce the episode. We just have to be little tactful to tell them that we want you to show the episode, so actually can bring in the episode with some suggestion. Post-ictal phase is not there in non-epileptic events. So immediately after the seizure, the child is absolutely all right. But in seizure, there is often a post-ictal event of drowsiness or lethargy. These
And
are
what are the things which we will, in adolescent specifically, the choices of the drugs, what you want to, what are the important consideration you want to take in adolescent age group?
So, because adherence to treatment is very difficult in adolescent, we have to look at the dosing schedule. It should be less number of doses per day. Side effects, if that treatment is effective, the choice of AD should be correct. The patient should not be stigmatized. So avoiding drug during the school time or during the college time when they have to take drug at that time becomes very difficult. So that has to be taken into consideration. Gender often is an important factor which has to be taken into consideration because
Dr.
some drugs are better for women, some drugs are not
Dr.
good
Vineet?
for the hormonal
Madam,
act.
I will just take a last 1 minute.
Yeah,
This will
actually,
be
we want
running.
Shefali madam's comments
Yeah,
also.
of course, of course.
Mm.
Yeah.
So what is this, Ekta? If the patient has
This is
started
gum
on this
hyperplasia because of
and
phenytoin
left-sided hirsutism, common with which drugs?
with valproate.
Well,
And hair loss is common with?
Lot of drugs,
So you
including
can see
valproate,
in with the
topramate.
valproate 2 to 24% may have hair loss. Rest other drugs may have 1 to 10%. Obesity, so very important concern in adolescent. So drugs which increases the weight is valproate, 40% may have a weight gain, gabapentin, pregabalin. And in the weight loss category, we have topiramate, lamotrigine, zonisamide, and levetiracetam. So always choose these drugs wisely and use their side effect as a beneficial effect for the patient. For the rash, the carbamazepine, oxcarbazepine, lamotrigine, phenobarbital, and phenytoin is known to cause such rashes. So this is again an important thing. About the behavioral side effects, I think this is something which is very important as far as adolescent is concerned. So the drugs which are very safe mood profile is lamotrigine, carbamazepine, and valproate, which is often used as a mood stabilizer as well. So you will have we will have a soft corner for using these drugs. And the other drugs, like even the levetiracetam, which is the most commonly used drugs, do have a lot of behavioral side effects, and that holds true with a lot of these all drugs which are mentioned here. And lastly, the pregnancy, the valproate and phenobarbital and phenytoin has the highest risk of having a congenital malformation, and the safest what is in the pregnancy is lamotrigine and levetiracetam. So take home for this panel is not all headaches are migraine. A systematic approach can lead to a better management. Seizure mimics are common. Make sure they are true seizures, address the triggers, and epilepsy diagnosis and management needs really an expertise. So thank you so much, all my panelists, for being so generous and giving the comments in brief in short of time. I want Shefali madam to have an expert comment. She is our AOCN president. Madam, over to madam.
Thank you,
Again,
Vineet.
thanks.
The most dynamic person around with the dynamic young ladies there. So I think that was very nice. I think the most common problems which any pediatrician would face in pediatric neurology would be epilepsy and headache. I think they're the most common, and you've made very wonderful case presentations.
Madam,
For
please
headache,
mute
I did
everyone.
mention the comments earlier. You have added on to the cases wonderfully, especially along with the migraine thing. Epilepsy, it's something very important. When you have seizures, it is important to understand the most important information is seizure semiology again. You're talking about history. I mean, no other thing can give, and everybody has smartphones. So we have to tell all our parents that you please video record any event which is going to happen. So I think that is something very, very important because 95% of the people are having smartphones. So that would be giving more information about the same. And another thing is, we have to understand, take the proper do. Firstly, as you had suggested in one of the cases, yes, actually gone are the days when Phenobarb were there. I don't think Phenobarb is now available, at least in mostly places. But yes, you have to be very clear about the choice of the drugs. The drug, firstly, you have to, firstly important is that you did mention about the non-epileptic events. You have PNEs which are there. One has to be very clear. So I said that seizure semiology has to be second. So video recording of the event, all the parents should be told to do. And also seeing the circumstances, you can very easily, for adolescents, very easy to, have cues that it is going to be a psychogenic non-epileptic event. And in that situation, you already also know that it's there when in front of somebody. It will not be there in sleep. Sometimes parents say it is in sleep and you just get carried away. Actually, it is not in sleep. It is when the child is lying down to go to sleep. So again, the history is going to come and save you, because history is going to tell you when the child is about to sleep, he starts having, and it's not that he's woken up from sleep. So certain things to delving into it, seizure versus non-seizure. Secondly, getting the understanding the seizure type and giving proper medications. And something really I feel in practice, one thing is important. One has a seizure, you get the right drug, then you start with small doses to a maximal tolerated dose of that particular drug. But many times what I see, unfortunately, in practice, that one child throws a breakthrough seizure, then goes to one pediatrician, he added a second drug instead of increasing the dose of the first drug. Then he goes to another pediatrician, he adds another drug instead of adding the dose. So we have to understand that you start with an appropriate drug. Yes, as very rightly presented by the panel, go from small dose to the, from the small dose to the maximal tolerated dose. And then again, seizure occurs and you add the second drug and withdraw the first one. And only after this exercise, then third time you start an add-on. And sometimes when child is having a lot of seizures, or when in neurocystic circus, you've given albendazole, you've given cysticidal therapy along with steroids, and there's going to have breakthrough seizures, then you may add a benzodiazepine for the, for the time, that time. But, and the other thing is the timing of the drugs. For adolescents, they should be convinced to have the drugs. Many times they don't take it. The compliance, they should be supervised. They should be not throwing it away because it's their mood which is dependent upon. Another thing is, you are not supposed to half those chronic sustained release tablets. Otherwise, the sustained release tablets halving thing, if you give them, say, Epilix chrono, here, or whatever chrono, some 1.5 BD. It doesn't make the sense of having a sustained release preparation. So that is something important. And some children, although adolescent, may chew the tablets. They may not swallow it. In that, again, situation, you don't give sustained release. Another thing, if they need syrups, then you need to give them with measured amount and not give it in, approximately. Another thing is, you have to tell them that you are not supposed to keep changing brands. I'm not telling you take XYZ brand, but whatever good brand they're taking, the brand should remain the same for these, because the pharmacokinetics and the bioavailability of the medication may change from one brand to the other. And in case, like obviously not in adolescent, but sometimes some adolescents don't want to take tablets. I know one of my very close relatives, he's now 18, but he still takes syrup. And, so for antibiotics, you have 6 bottles finishing in 1 or 2 days, so it becomes really difficult, but then you have to handle them. So I'm just saying that in case they're asking syrup, then you have to shake the suspension, because otherwise what happens in the top, you will not get the medicine at the bottom. There'll be too much medicine. And be very careful about the combination of drugs you use. Actually, when you add the anti-seizure medications, you should use drugs which have two different mechanisms of action so that it becomes an additive effect. Another thing is they should not be having the similar side effects. Like you are going to give valproate and topiramate, suppose, so they both are having rising ammonia. So you need to do and follow up. So they should be different modes of action ideally, and they should not be having similar side effects, because then they're going to add on. So these smaller cues and all will help go a long way. And we maintain a seizure diary, we need to give. And very important, which I think got missed today, is domiciliary management of seizure. And I feel that any child who comes to any pediatrician with a seizure, whether or not epilepsy, has to be given the intranasal midazolam spray prescription and told. So in case you need to see the video, there is a video on www.3w.ped is pediatric, neuro is neuro, aims.org. We have a parents corner. In that parents corner, you have domiciliary management of seizures, also one of the videos in Hindi and English. And so in that, how to position the child in recovery position and give the intranasal spray of the midazolam. These are very important things. And you need to tell parents not to panic and tell them what to do and not to do. So in case you need to give to your parents, we have epilepsy patient information sheet in English and Hindi, for something for febrile seizure, something for NCC separately, dietary therapy, seizure diary, and a seizure card. Seizure card, we have made that anterior side. I have made a male, a boy or a girl, both. So for demographics on the reverse, how to position the child in lateral position when the child has a seizure, and the dose, the nasal spray dose. And I tell the parents that you should keep one, you should buy two sprays, one keep at home and other you keep in the school bag. And the child should have that seizure card laminated and put, carrying. So all these small things, and I feel that there are two things which Indian population should know. One is CPR, because anybody can have an arrest anywhere, and post COVID, very young people are having cardiac events. Second is management of seizures, because anybody can seizure anywhere. And we don't have 911 services. We cannot crib about it. We are a developing nation and on a lower middle income resource. So I think we should empower each other, not only doctors, everybody should know how to, handle this seizure. So you can check the website for the domiciliary management. Thank you. It was wonderful session. And I hope the friends have,
Thank you so much, madam.
knowledge is there. And we have a very young brigade, very bright, brilliant. And Praveen was amazing. Vineet is amazing. And Ekta and every one of you, Anusha, and Dr. Neelam, all of you have been amazing. And Hima Bandhu is anyway amazing.
Thank you so much, madam, for being so generous that you, in spite of AOC's organizing president, after 15 days, you have a conference, you spare time for this webinar.
15 नहीं है, 15 नहीं है, 12 दिन है.
12 दिन के पहले आप
12
आए.
दिन ही.
Thank you so much for
Actually,
sparing
I
that
should
4
Yeah,
thank
hours.
Shefali.
thank you, Shefali, for summarizing it so
MK
beautifully.
sir. Yes, sir.
Madam,
Your
one sec.
comments.
One sec. Thank you, Shefali, for summarizing it so beautifully. And Vineet, I must really congratulate you. You are a fantastic teacher. I'm
Thank you,
telling
sir.
you, I can see that you are a fantastic. You ask questions that most of us want to ask. You are asking the panelists those questions that we want. Just to clarification. This is not for knowledge, but just for clarifying for parents. Going outside and eating, does it have anything to do with as a provocating factor? Number one. Number two, all the children you said are 14. I'm sure it cannot be 14, all of them. So some of them may be going for dating. Any date drugs can create problem. These two questions.
Which drugs, sir?
Dating, they use some drugs.
Sir, usually this diet, the deprivation of this. Shefali madam want to take this? It's better.
Both of you can give a comment, because most parents ask this question.
So can you come again, sir? The question
I'm
was?
saying any
Yeah.
drug, you go and eat. Most of the time you said he went for dinner, next day had the problem. Anything in the food, can it have an effect as a triggering? I'm not saying it will cause epilepsy, but as a triggering factor. Any evidence for that? For example, some people talk about Chinese food creating.
I'll tell you. No, but not directly, sir, in that. But what happens is sometimes that it has been there seen like if somebody has hypoglycemia and some of the metabolic disorders. So in that situation, you may have in certain metabolic conditions with hypoglycemia, you may have in the situation. But otherwise, sometimes parents do see and but there is no direct physiological basis. Parents do say and mostly it is just with physiologically you can think of hypoglycemia and all causing, but otherwise I don't
No,
think
nothing to do with Chinese food and all that.
yeah, no, although that
Just a
has been a lot of
clarification I
blame.
needed. Second
But I'll
one
tell
is,
you what, I'll tell you something.
Ah.
Something which is very preventable cause of epilepsy is neurocysticercosis. So if
Of
you
course.
cause something die, it will not cause immediately the next day. But
Yeah,
yes,
North India,
no,
North
no,
India
but in
neurosis
North
is
India
a
too much.
huge problem.
North India too much
Ah.
because improperly washed fruits and vegetables and
Yeah, okay.
everywhere you put coriander. Every time you have this this cabbage, coleslaw sandwiches, the burgers and all that with the lettuce and all. So that is causing, and I think that's a public health issue in the North India. But it is coming down. So it is coming down in the last 25 years. I've seen it's declining.
Second one is about date drugs. Go for dating, they give you some drugs.
Sir, I'll tell you. I mean, I have not read about it anything, but yes, there is a possibility. And anyway, drug abuse can lead to seizures. Yes, they could be symptomatic seizures with some substance abuse and all drugs. They can be seizures which can take place. Yes, and even with the alcohol and all also. And when they mix alcohol and drugs, that can lead to some seizures. But yeah. But I think, I have to also start reading about all these date drugs because I'm not thinking about adolescents. So I
Adolescents.
Yeah, pediatric neurologist, madam.
Collaborate with AHA.
You better do adolescent.
No,
Yeah,
sir. 18 years, till 18 years, you have pediatrics. So I have to look after adolescents. But this,
yes, Dr.
I haven't read
Shefali.
about date drugs. Yeah.
We look at you only to handle adolescent issues. Please, you need
Definitely.
to.
No, I'm
Yeah.
supposed to look up to 18. But you know what, sir? I have patients who are actually 42 also. They've come to me with their wives. I tell them every time that transitional care is sent to this adult, but they'll again come back because they've been talking to me for,
Yeah, it happens. Yeah.
Yes.
So thank you, Dr. Shefali. That was so nice, wonderful session today. And Dr. Vineet, thank you. As Dr. M.K. Sinayar commented, I also found that you really moderated the panel excellently. And somebody said that you had young neurologists on board. Yes, we wanted the expertise of Shefali Madam, Dr. M.K. Sinayar. At the same time, Vineet is a moderate, he was real, very good. And we had Anusha Raj. We picked her up and identified we wanted a pediatric neurologist, and we also had Preeti, all young people, and of course Ekta.
Praveen is also wonderful actually.
Young,
Praveen
yes,
is always wonderful.
Praveen, yes, he was so good. And there are those two common issues: headache and epilepsy, seizures disorders, and adolescents. And we pediatricians who are dealing with adolescents have seen this very, very commonly. And you have clarified a lot of things. And mostly, I think we appreciate the practical aspects were very much covered, including like what she mentioned, Dr. Chefali, about adolescents don't sometimes take the drugs. They are, they have these mood swings, and it's not easy to deal with adolescents like children or adults. So all those issues were brought out nicely. Thank you. And this is a recorded session. We'll be posting the link for all those who have not who could not attend. So once again, a huge thank you from Central AHA for joining. Special thanks to Dr. M.K. Sinayar sir, Shefali ji, and really thank you. But she just accepted, sir. I said, no, Shefali, we want you. And wonderful. I think we should think of something more programs with you.
Thank you.
Dr. Vineet ji, thank you so much.
Thank you, madam. Thank you so
And
much.
we look forward for involving the pediatric neurology chapter. Think about adolescent. I think we had here a youth voice. Nomika, are you still there? Dr. Nomika? Actually, we usually take their perceptions. She's actually a UNICEF, she's a lead for us in the youth voice, and she's an epileptic herself. So she said she will come and speak. Is she around? Dr. Monica's here. Or maybe we missed her. She was a little busy, but then I requested her. Yeah. Yeah, thank you, Dr. Preeti Srivastava, Dr. Anusha, Dr. Ekta.
Dr. Imabandhu, 1 second. I wanted
Yeah.
to mention somebody has written in the chat cannabinoids and MDMA in addition to alcohol can cause seizures. But I wanted to tell you that cannabidiol is also come up as a major new anti-seizure medication as well. But yes, obviously indiscreet, the ones which they must be using in dating drugs. Yes, that is there. That's why I was
Any
saying
more
that
questions? Yeah.
no, somebody's
Mhm.
mentioned. So I'm just saying, yes, I told you that substance abuse and alcohol, that mostly combination also adds on to drugs. But yeah, but cannabis has been now, they have removed they've got the better part of it, which is non-addicting and all for, it's been released by the DCGI also, permitted for use for anti-seizure medications for certain intractable epilepsies. Obviously, pediatricians don't need to send, it will be the pediatric neurologist will give. Just don't give cannabidiol to for epilepsy. We will give it in refractory cases.
Yeah.
Thank you. Thank you.
And did we answer this question? Can propranolol be used as prophylaxis for migraine in adolescents? Revati from Bangalore was asking.
Yeah.
Anybody?
Yeah, it can be used. It's quite
Yeah.
commonly used,
Yeah.
ma'am.
Yeah.
Yeah. So I think we are done with the questions. Geeta Patil mentioning juvenile epilepsy requires lifelong convincing. Okay, she has a comment. And home dots commonly used for TB is something very important. Adolescents are not getting controlled. Home dots commonly used for TB is something very important. Adolescents, especially where seizures are not getting controlled. I didn't get this question.
Ma'am, it's not question. Sudhir Mishra here. It's not
Sir,
a question.
yeah, we
Just a
welcome,
comment.
sir, you. Yeah,
It's just a comment
comment,
that
right.
seizures are not getting controlled and the compliance is an issue. It's the directly observed therapy by the parents. So what I advise them is to take the medicine in front of parents rather than giving tablet to the child. कि, okay, ठीक है, सुबह शाम खाना है खा ले. Like that.
Thank you. Sudhesh Mishra sir is a scientific chair of our AHA and he also picks up nice topics. And thank you, sir. We all are, I think it was a very successful webinar today. Thank you, one and all.
Dr. Himabindu, can I ask Dr. Vinny? Because
sure. Please go
this
ahead.
juvenile myoclonic epilepsy
Yeah.
is so difficult for us pediatrician because the moment you stop, sometime relapse happens. They say that lifelong. How to convince parents and adolescents? That is a big dilemma for us. How do
So
the neurologists do?
yeah, so basically, there are very few epilepsies which has a dictum that you should be continuing the lifelong anti-seizure medication, and JME is one of that. Having said that, we often do after 5 years. So we often give 5 years of treatment, and at the beginning of the counseling, we always tell them we will take a single attempt of withdrawing the medicines, a very gradual taper at the age of after the 5 years. So that's the usual take, and almost one third of the patients may do not relapse if they take care of these all 5 6 things, the sleep deprivations, if they control of their screen time, if they have the proper sleep hygiene, if they have proper dietary schedules and enough hydrations and no fatigue stimulations. So usually they do not have this thing in almost 20 to 30%, but 70 to 80% do have those relapses, and this is one of the condition. I totally agree with you. It's very difficult to tell parents that you will require a lifetime medication, but I think it's all the outlook of the as a clinician, as a neurologist, I often see what I consider I can means like if I say that it's okay being giving an anti-seizure medication throughout the life, because I give a lot of advices that my building is a 10-storied building and the owner is a very Agrawal person, and his daughter-in-law is having epileptic seizures, and though they got this daughter-in-law as a epileptic patient. So often I give that example, this is a very big building, but even you can become a daughter-in-law of that person in spite of having an epilepsy. She is having a JME. So I think that those analogs and what you talk and what the parent feels matter for the patient. It's not all at the end of day what all society and this all things. So if so you can use such analog while discussing, but it is often difficult for parents because they're real anxious if specifically they are girls. So I do agree, but that's the
Lifelong would
only
be
way out.
preferable, sir.
I,
What is a lifelong we
I
will see?
think one of the way that instead of saying you have to take lifelong, although that is a
5
fact,
years.
say that we will do it for 2 years,
Yeah.
3 years,
3 to
5
5 years.
years, then we'll
Withdraw.
completely
Withdraw.
reassess and see whether indeed most persons, although it's not true, you say most persons get out of it. But in
Correct.
case you don't do it, we may have to do it. So if you say lifelong, they are going to run away from you.
Run away
to
and they will go to
homeopath.
another doctor.
Yeah,
Yeah.
they are going to run away and go to a
Sir,
homeopath.
One or
actually,
two,
we never
one
say,
or
I
two
mean,
good. Yeah.
I never say lifelong, as you were saying, na. We just say it may have to be given for longish periods and
Correct.
it will have to be individualized. So one has to just come to a middle path, yes. And as
Correct.
Vineet was saying, giving examples, and I
Yes.
do give examples, because Alfred Nobel's you get the Nobel Prize. He had epilepsy. Jaunty Rhodes, they know, cricket Joel hai, so I tell them, and then he had epilepsy. So like this, I give examples, and in that situation, as he was suggesting, I mean, that is right. And just you're not hiding anything, but you don't have to tell the whole prognosis. For lifelong prognosis doesn't have to have in the first counseling. You just to say it
Correct.
may have to be given a longish period. And I mean, they have to be made to understand I mean, it's very clearly, I tell them there's a risk benefit ratio. And if you, and for the compliance also, the kids have to be told that, and if you have a prolonged seizure, you may have a damage to the brain and all that. So I think the way we talk, we should be convinced, and we should be a little bit careful in talking, and slightly diplomatic in the sense that if we say lifelong, obviously they will not they will run away, in the sense they'll
Run
obviously go
away.
and look for. So run away was okay, said jokingly, but I mean, they will go and seek somebody else who tells them ki, nahi, it's going to be stopped after some time.
Yeah.
Correct.
Because that's what I mean. It's not running away from you, going to somebody who'll say what they want to hear.
Madam, even worse, they may go for completely homeopathy, Ayurveda, and all
Yes,
this. They
yes,
won't
yes.
take
Yes. Yes.
That is another
anti-epileptic drug
possibility.
at all.
Very, very
No,
That's the
likely.
sir.
worst part. Let
No,
them
no.
go to
Once
another
it,
neurologist, doesn't matter. But if they go away from the whole medicine, and then that
Correct.
create more problem. Yeah.
Correct. Correct.
absolutely, sir. Absolutely. They
Absolutely,
go to
sir.
the jadboot thing also without
Mm.
any medication.
Mm. So, Nai, thank you that we got this very practical aspect of dealing with adolescents, a chronic issue, and how they have to accept and how we need to counsel. I think that was one of the most practical aspects, apart from the knowledge of what medicine to take, how to convince an adolescent about the prognosis and the medications. That is a very, I think, most practical aspect of dealing with the adolescents. Thank you to bringing that point also on board.
If you have
Sir,
still doubt, you should ask those who are treating type 1 diabetes or juvenile diabetes group. They know how to manage. Again, it's a lifelong. The
lifelong.
adolescents, because we have a huge group, they actually listen to you much better than these parents.
Correct.
They
Mm.
create problems. The children, once they understand what exactly, but they need to be told exactly why we are doing this. Then they are much more cooperative than we ever imagined. They can be this same. So you can consult them how you manage this lifelong diabetic treatment.
Absolutely true, sir. Yeah. Thank you. I think it was very, very interesting, sir. Happy Onam to
Thank you,
all
sir.
of you, especially to Dr. M.K. Nair, sir, and
Sir.
Anusha, everybody, Shefali, everybody.
Sir,
Thank you so
unmute
much.
yourself.
It was
Thank
excellent,
you.
and very good night to all. Thank
Thank
Good
you.
you.
night, ma'am.
Thank you.
Good
Thank
night.
you,
Thank you,
ma'am.
everyone.
Bye.
Good night.
Thank
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 you,
you.
you.
Good
everyone.
night.
Good
Good
night.
Thank
night.
you.
Thank you.
Bye-bye. Thank you. Thank
Thank
you.
you.
Thank you. Thank you, everyone.
Thank you. Maybe we can end the meeting. Srinivasa sir, thank you for joining from really, really far. Thank you so much.
Thank you. I must thank you.
Thank you. Thank you.